Welcome back. Today we're going to do the normal elbow standard projections. Now, the view you're seeing right now is an AP projection of the elbow. The other standard projections include medial oblique projection of the elbow and a lateral oblique of the elbow. Some places you'll see it written as only including an AP and a lateral. Now, the medial oblique projection is encouraged simply because you can see the osseous structures in a slightly different orientation somewhere between AP and lateral. But at many locations, this extra view is not performed, so don't fret. Just know that an AP and a lateral is technically inclusive. However, a medial oblique would be extra useful. Just starting with the most obvious, here is the humerus. Here is the radius, and here is the ulna. Now it's important to remember that the radius is on the thumb side, and that in anatomic position, this is actually the lateral aspect of the forearm. The ulna is on the pinky side, or the fifth digit side of the hand, and is effectively on the medial aspect of the forearm. Now this happens to be a left elbow. We've collimated out the marker, so I just want to draw that in for you. Now let's go through some of the normal anatomic structures. Let's begin with the humerus. Here is the medial epicondyle, and here is the lateral epicondyle. Now in adulthood, these structures are relatively stable. However, in childhood, these structures are prone to fractures, specifically avulsion fractures, as well as supracondylar region fractures. So it's important in the pediatric population to pay close attention to this region. Now, as we all know, this is an adult patient or a skeletally mature patient, and therefore no growth plates are open. However, in the pediatric population, there are multiple secondary ossification centers that develop in this location that can be pulled off and create avulsion type fractures. It's important to know the order of appearance of these secondary ossification centers, because sometimes we'll avulse off a fragment of bone and then we'll make the mistake of calling it a normal secondary ossification center. So quickly, I'm just going to give you a little acronym to remember the order of ossification center appearance, and it's actually uses the letters CRITO, C-R-I-T-O-E. And this is the order of appearance of the secondary ossification centers of the elbow, starting with the capitulum, next radial head, internal epicondyle, trochlea, olecranon, external epicondyle. And so these ossification centers should show up in this order. If you're seeing, for example, what looks like a olecranon ossification center, however the radial head ossification center has not appeared yet, you know in fact that the fragment you're seeing is a fracture. So this may be useful. I'll do some pediatric tutorials in the future. However, I felt that it was important to mention that. Now let's continue on with the anatomy. Here, this lucent region on the humerus is the olecranon fossa. This will receive the olecranon process. This is actually a posterior structure. Now, here is the articular surface or condyle that articulates with the olecranon, which makes this the trochlea. Here is the other condyle, which articulates with the radius. This is the capitulum. Here is the radial head. This region is prone to fractures in adulthood, especially patients who fall on outstretched hands. This is going to be the most common location for fractures within the arm within the elbow when that mechanism of injury is sustained. Here is the radial neck, which is the thinner portion just distal to the radial head, and here is the radial tuberosity. Moving on to the ulna, here is the olecranon process, which we're looking into, and here's another portion. This is the anterior most lip of the olecranon, which actually has a coronoid tubercle, which we'll talk about. You can see better on the lateral projection. Here is the ulnar shaft, radial shaft. So there's not that many structures to evaluate in the elbow. Of course, this is the radiocapitular, or some people say radiocapitellar joint. Here is the ulnotrochlear joint. We will now move on to the oblique projection. So here's the medial oblique projection of the elbow. You can see that it doesn't exactly look like the AP, and it definitely doesn't look like a lateral. Now this projection will allow you to see through the radiocapitular joint very, very well, as well as see the radius and ulna in a slightly different view. Now let's just begin again. Here is the humerus, here is the radius, and here is the ulna. Remember that the ulna is on the medial side, and remember that the radius is on the lateral side. So when we come up to the humerus, this is the lateral epicondyle, while this is the medial epicondyle. Here is the capitulum, which articulates with the radial head. Here's the radial head, and of course the radiocapitular joint or capitellar joint. Here is the radial neck and radial tuberosity. Continuing on with the ulna, well, let's just identify the Electron fossa, which is the fossa that receives the Electron process. Now the Electron process we can see very nicely here. It's kind of this spoon-shaped structure that extends off of the proximal ulna, and this will articulate with the trochlea, which is the condyle, the medial condyle of the humerus, to create the ulnotrochlear joint. Now the elbow pivots quite a bit, almost 180 degrees, and so the olecranon articular surface actually wraps around quite a bit of the trochlea and allows for this nice pivot action to happen. Now there is a joint space that's created between the proximal ulna and the proximal radius, and this is called the proximal radial ulnar joint. When we supinate or pronate our hand and wrist, which basically means to turn our hand over or back, this is called supination and pronation. This action creates a long axis rotation of the radius upon the ulna. And so there's quite a bit of rotation that occurs here. Now there is an anomaly called radial ulnar synostosis. Syn meaning together, ostosis meaning bone. Synostosis can create, or basically is a fusion between the radius and ulna. It's most commonly in the proximal third or so. But that fusion prevents supination and pronation. So it's very important when you evaluate these radiographs to just make sure that the radius and ulna proximally are indeed separate and have distinct cortices between them. In terms of the medial oblique projection, I think we've covered all the anatomic structures we can see well in this location, and let's move on to the lateral projection. So here's the lateral projection of the elbow. You can tell we're looking at the elbow from a lateral perspective. Humerus, radius, ulna. Now this is a great example of what I was talking about before, just to make sure that the radius and ulna are completely separate, and as you notice here, there is quite a bit of space between them. There is an interosseous membrane that lives in this location that holds the radius and ulna together, in addition to the joint capsule created by the proximal radial ulnar joint, which lives in this location. Now here's the radial head, which makes this the radial neck. The radial tuberosity we don't see very well on this projection. Here is the capitulum, which is articulating with the radial head to make the radiocapitular joint. Now coming back to the ulna, here is the beginning of the Electron process. The Electron process comes all the way around and extends here. Now this very prominent point right here is called the coronoid tubercle. Coronoid tubercle. And this little tubercle can fracture with hyperflexion injuries of the elbow. And so it's important to take a close look at that. Now the trochlea lives here, and this patient wasn't positioned exactly optimally, and you are seeing a little offset between the humeral condyles. However, we can know that this is the trochlea because the capitulum we've already identified articulating with the radius here. Now there's a soft tissue region that you need to pay close attention to, and the region is back here behind the humerus. Now typically with elbow injuries, it's sometimes hard to see some of the smaller structures of the elbow, and so if in fact there is trauma to the elbow or to the osseous structures or even to the joint or the joint capsule, the region will swell. Since the joint capsule is so closely approximated to the shaft of the humerus, we don't see any alterations in density in the soft soft tissues normally. However, if there is joint swelling, this region will begin to, the joint capsule upon joint effusion will begin to separate away from the humerus, and it fills with fluid or blood depending on the type of trauma that's been sustained. What ends up happening is you'll get a water density next to a soft tissue density, and this is indicative of joint effusion. They actually call this lifting and the visualization of lucency here the sail sign. Now, some texts will say it needs to be combined with a similar finding along the front to create a sail-like shape, and this is called the sail sign. However, the posterior aspect is what's most important, and they actually call this a positive fat pad sign, which means that the fat pad has been distended away from the humerus, indicative of a joint effusion. Now, if you see this, it means that there is an effusion in the joint, and there most likely is damage to some structure within the elbow joint itself. Oftentimes, you will need an MRI to evaluate that finding if it's not conspicuous on the radiograph. So the posterior fat pad is a nice indicator that there is some internal derangement of the joint, even if it cannot be seen radiographically. So just be sure to look at the soft tissue in this region. I think we've covered most of the anatomic structures here. I just wanted to quickly talk about some alignment issues. Now, one of the things that we need to evaluate is for proper alignment of the radius relative to the humerus, and one way we can do that is with this radiocapitular line. You're essentially drawing a line through the parallel to the shaft of the radius along the mid aspect, and you just want to make sure that this line intersects the mid portion of the capitulum. With radial head dislocations, like say for example if the radial head moved up here and we drew this line, you could see how it would be grossly abnormal and not approximating the capitulum. One other alignment issue that we need to be aware of, especially in the child, is this anterior humeral line, and it is drawn simply as it's named. It's an anterior humeral line that you draw along the anterior humerus, and this line should basically intersect the condyles of the humerus as well. The reason why we draw this line specifically in children is they can sustain supracondylar fractures, which is the most common type of elbow fracture sustained in children, and at that point we can get angulation of the distal humerus, at which point the anterior humeral line we drew would not intersect the mid portion of the condyles, basically indicating a supracondylar fracture. Now, of course, you will have multiple views to evaluate this on, and so this should not be the only view to see that finding if it were present. However, multiple views and alignment relationships are useful when you're trying to evaluate for abnormalities. This concludes our elbow tutorial. I hope this was useful, and please join us for future tutorials.